For most people, when they commence some form of physical activity that they are not accustomed to, or they've been away from the activity for some times and they recommence the activity that they normally do, you'll find that muscle soreness will follow. These activities do not always have to be exhaustive or at very high intensity. So in this presentation, we're going to be exploring these muscle soreness in a little bit more detail. We established that there are two different types of muscle soreness. There's acute muscle soreness and the delayed onset muscle soreness. Then we're going to be talking about the mechanism that can cause these muscle soreness. Believe it or not, the actual mechanism or the detail of it is still quite equivocal and it's still not fully understood by scientists and researchers. But we are becoming more and more aware of some of the things that contribute to this soreness. And by knowing that, it may allow us to come up with better strategies that enable us to deal or to manage or minimize muscle soreness. So firstly, the acute muscle soreness. This is the pain felt during and immediately after exercise. And it can be due to the accumulation of any end products of exercise, such as the hydrogen ion, and also from what we call tissue edema. This is essentially fluid shifting from blood plasma into the muscle tissue. So the pumped up sensation that people feel after a fairly hard training session is due to this edema effect. The good thing about this acute muscle soreness is that pain and soreness usually disappear within a few minutes and can go up to several hours after exercise, and that is about it. The second type of soreness generally appears about a day after exercise. The major sensation is obviously ache and pain, but it's one that is exacerbated by pressure and movement. This soreness can begin as early as 12 hours after exercise, but generally peaks at about 48 to 72 hours after the exercise bout. The delayed onset muscle soreness is termed as such because the soreness or the pain occurs quite a way after the cessation of the exercise, but it is classified as a type 1 muscle strain injury. The symptom can vary from slight muscle stiffness to fairly severe debilitating pain that can restrict movement and other function of the muscles. While the mechanism of DOMS is not fully understood, and we'll explore that in more detail a little bit later, we know that delayed onset muscle soreness typically occurs after performing unaccustomed activities, and it may be experienced when a healthy individual resumes an activity after several weeks of break or inactivity. More importantly, almost all research tend to agree that eccentric contraction or exercise with strong eccentric component tend to lead to DOM, and essentially it's concluded that eccentric contraction could be the primary cause of delayed onset muscle soreness. Along with the pain and the discomfort felt with DOMS, what you also see is some impairment in muscle functions. Firstly, soreness tend to accompany muscle stiffness, and with stiffness you see a reduction in effective range of motion of the muscles, and that will last throughout the time course of the soreness. What you also see is a reduction in muscle strength, and that can occur pretty much immediately after cessation of exercise, so prior to the onset of the delayed onset muscle soreness, and it can last for up to about 1 to 2 weeks after soreness has remitted. So the functional impairment of soreness, it can last for quite a while. I just want to focus a little bit on the eccentric action and how it is associated with delayed onset muscle soreness. And I'm presenting a couple of studies that have shown exactly that. Okay, first one is from Frieden and his team back in 1986. They're from California. And essentially, they looked at within subject design, examined the effects of concentric exercise versus eccentric exercise on delayed onset muscle soreness. Essentially, it is a within subject design, so one person went through both exercise modes. In this case, it's a dorsiflexion task. So the left leg performed a concentric dorsiflexion contraction, and the right leg performed the eccentric dorsiflexion contraction, and both did 400 repetitions using the same load. And what the study did also was get the subject to perform the contraction at the same rate. So it was 20 repetitions per minute for 20 minutes. Now, 2 days after exercise, all subjects reported fairly severe soreness and stiffness in the tibialis anterior and the anterior compartment of the shanks off the eccentrically exercised limb. These symptoms were markedly aggravated during the palpation and isometric contraction tests. Interestingly, no pain was perceived or reported from the concentrically exercised muscles. Some experience reported occasional stiffness, but none reported soreness in that limb 2 days after exercise. Similarly, this group looked at soreness following downhill running compared to running on flat ground at the same speed. Running downhill is recognized as being associated with a strong eccentric contribution from the muscles, and particularly because you're landing at a little bit more velocity, and there's a little bit more impact at landing at each step. The concentric contribution is a little bit less because you don't actually need to propel yourself or try and drive yourself as high off the ground to take the step for clearance, and is recognised. It's pretty well accepted that downhill running has a fairly strong eccentric component. So what they did, they also found that DOMS, or delayed onset muscle soreness, was only experienced in the legs after downhill running. Subject essentially did both flat ground and downhill running about 7 days apart, and it was randomized as well. The order, essentially no soreness was observed in the flat ground running, regardless of the order. So these two studies that I just presented demonstrate fairly unequivocally that the eccentric contraction play a significant role in delayed onset muscle soreness. While the physiological events that leads to DOMS remains fairly unclear, it is believed that injury or damage to the muscle initiates the response that leads to the muscle soreness. And as we talked about before, eccentric contraction is the biggest contribution of that muscular damage. So muscle damage potentially has a very important role in whether you're sore or you're not sore after exercise. This figure illustrates or is an electron micrograph profiling of normal muscle ultrastructure, and you can see there muscle fibers are running horizontally, and you can see a number of fibers there the striated pattern, the dark line represent the Z disc that separate each sarcomere, which is the functional, that contractile unit of the muscles, if you can recall that information. And you can see they line up pretty nicely, pretty neatly organized, and that's going to optimize force output when the muscle contracts. Following a 30-minute downhill run, the biopsy of the muscle shows some disorganization of the myofibrillar ultrastructure. You can see that the Z discs now are not in alignment of one another. You see some clearly some disruption in the Z disc in a day after the run. So this third slide here is a biopsy taken one day after the downhill run. You can see misalignment, some disturbance, streaming of the Z disc. So you can see a marked impairment and damage to the ultrastructure of the muscle fiber. The good news is that the recovery of the muscle fibers occur, and that size is taken 14 days. It's not completely recovered back to what you saw in the first slide, but you can see that the organization is quite neat once again. And at this time, delayed onset muscle soreness is well subsided. While it is generally agreed that muscle damage may precipitate delayed onset muscle soreness, keep in mind that it may not directly cause it. After all, every time we exercise, we will sustain some damage to the muscle fiber. So damage frequently occur even though the exerciser experienced no muscle soreness. We also know that if you start doing some new exercise, you experience soreness, you do that same exercise, but even though you maintain that high intensity for weeks and weeks and weeks, you don't get as sore anymore. So even though muscle damage occurs, soreness doesn't necessarily occur in parallel to the muscle damage. Keep in mind that muscle damage appears to be precipitating factors also for muscle hypertrophy. So with cellular or structural damage, it triggers a series of events that cause muscle to regenerate and to go bigger and stronger. So it is now accepted that delayed onset muscle soreness results from the injury or damage to the muscle itself. What I'm going to present here now is a suggested chain of events, if you like, that leads to delayed onset muscle soreness. Keep in mind this is only a hypothesis drawn from a series of findings and a series of theories as well that suggest that contribute to DOMS. The exact mechanism obviously is still not known. So this is quite speculative. But what we do know is injury to the muscle is a critical factor. What you then see is an accumulation of calcium within the fiber, and what happens then is maintenance of the calcium balance is disturbed. Consequently, you see a production of the proteolytic enzymes that degrade the muscle, the myofilaments even further. So the sarcomeres, troponins, tropomyosin. So these are proteins within the myofilaments. Within a few hours, you also see significant elevation of circulating neutrophils, which is a type of white blood cells. So your immune system respond by supplying these neutrophils into the damaging tissue. Intracellular components and markers of connective tissue damage and muscle damage also diffuse into the plasma and interstitium. These substances serve to attract monocytes, and with around 6 to 12 hours, they will then convert into macrophages. Most cells and histamine production are then activated and what you see within hours, there's also a significant elevation in circulating neutrophils, again these white blood cells, at the injury site. Next stage is when you see accumulation of monocytes and macrophages. The number peaks at about 48 hours after the trauma incident, so this is exercise. Upon exposure to the inflammatory environment, macrophages produce prostaglandin that sensitizes nerve endings to mechanical, chemical, and thermal stimulation, essentially trigger the pain. So these series of events lead to sensation of delayed onset muscle soreness. Soreness may be increased with movement, as the increased intramuscular pressure creates mechanical stimulus for pain receptors already sensitized by this prostaglandin. Again, at present, the sequence of events remains hypothetical. It is evident that further research is warranted to validate the biochemical and cellular events that occur leading up to the onset of muscle soreness. Regardless of the mechanism, we know roughly that it's eccentric contraction that leads to DOMS, and there's some structural and muscle damage and potential some form of inflammatory response. That knowledge provides some guidance from some of the common strategies to manage and prevent and alleviate symptoms of delayed onset muscle soreness, as well as restore some muscle function in a timely manner, of course. Because it's not fully understood, because these mechanisms are still hypothetical, these strategies, you'll find that it can be a bit of a hit and miss. As DOMS is considered as a strain injury with associated inflammation, cryotherapy or ice has been suggested as a way to reduce inflammation by reducing tissue temperature, and reduction in tissue temperature stimulates cutaneous receptors to constrict local blood vessels to reduce local blood flow. This then results in a decreased rate of metabolism that in turn reduce inflammatory response and edema. However, while cryotherapy may have some positive analgesic effect, studies have shown little or no attenuation of DOMS, nor facilitation of muscle recovery following application of cryotherapy. This contrasts with application of cryotherapy to acute trauma to the soft tissue, which may question the role of inflammation on delayed onset muscle soreness. Static stretching has also been recommended as preventative measure of DOMS, and it is thought to relieve the muscle spasm. It has also been later proposed that static stretching of sore muscles post-exercise could also force the dispersion of edema, which accumulates following tissue damage. However, these assumptions have also been proven false. Where stretching can be beneficial is that it enables the stiffened muscles to be lengthened and thus maintaining optimal or near optimal range of motion despite muscle soreness and impaired muscle function. Homeopathic treatments have also been suggested to or used to try in attempt to alleviate or manage delayed onset muscle soreness. And the most popular homeopathic medicine of choice is a substance called arnica, due to its analgesic, antibiotic, and anti-inflammatory properties. Studies, however, have shown minimal benefits of this remedy. In a randomized, double-blind, placebo-controlled trial, no statistical differences were found in mean muscle soreness following bench stepping exercise that induced delayed onset muscle soreness between placebo group and the arnica group. The influx of calcium ions into the muscle fibers and subsequent disruption of the calcium homeostasis following eccentric exercise may be restored by increasing the amount of oxygenated blood flow to the injured area. It has been suggested that an increase in blood flow during vigorous massage can hinder the margination of neutrophils and reduces subsequent prostaglandin production. This therefore reduces any further damage associated with the inflammatory process. However, studies that have examined the effects of massage on local blood flow have shown varying results. Studies examining the effect of massage on the perception of delayed onset muscle soreness also vary. Inconsistencies in research finding may be due to the large variety of techniques the therapists use and duration of massage. So evidence at this point is quite inconclusive. Another methods that have been suggested have shown some promise in managing delayed onset muscle soreness is the continuous compression. And this can be from wearing from strapping to wearing compression garment that you see people wear all the time. So far, there's been little evidence to show that they work, but only because there's only been a few studies that have looked at this type of or this strategy. One particular study by Kramer and his team. Kramer is one of the well-known authors in strength conditioning field. He looked at, or basically they demonstrate the benefits of continuous compression as they were found to help decrease perception of soreness, reduce swelling, and promote some level of recovery. Now, it is unclear how much of that is due to the placebo effects, i.e. because they know they're wearing the garments, so they just feel better because they're wearing them, rather than the direct benefits from the compression garment itself. As this is only one of the few studies that show benefits of this type of this strategy, more investigation is required to confirm or substantiate these benefits. Another strategies that have been proved to be somewhat effective for alleviating soreness, even though pain relief is quite temporary and can resume again fairly quickly following cessation, is exercise. So lower intensity exercise can be quite useful. It had been proposed that these temporal effects may be due to the breakup of adhesions in the sore muscles. An increased removal of noxious waste product via increased blood flow or increased endorphin releasing during the activity are also suggested to be beneficial. The latter, which is the endorphin release, can result in an analgesic effects that minimize sensation of soreness. Here's a study that have shown the benefits of lower intensity exercise on pain reduction, if you like, while the subject experiencing DOMS. So in this case, the DOMS inducing exercise was max 60 repetition of maximum effort eccentric elbow flexion extension. So elbow extension, flexion extension done in an eccentric manner. During the recovery phase for the 4 days following, on each day, subject performed 600 flexion extension action without resistance. So it's fairly effortless, just move your elbow through that range. What they found was that immediately after the light exercise, participant experienced reported about 40% reduction in soreness, and tests showed about 5% increase in range of motion. So some reduction in that passive resistance. Didn't last too long, but the effect was quite immediate. Interestingly, maximum strength tests showed absolutely no differences between the group that did recovery and the group that didn't. So they show that light exercise can have some temporary pain reduction benefits, even though it doesn't really help with muscle recovery of any muscles impairment, if you like. What about prevention strategies? Rather than have to try to deal with delayed onset muscle soreness after every training bout, a good way to perhaps get people to enjoy more exercise more is to try to limit or prevent delayed onset muscle soreness. One way that has been suggested is to perhaps reduce the eccentric component of muscle contraction and then introduce this component gradually as one progresses. Keep in mind that it's really difficult to get rid of eccentric contraction entirely out of your exercise routines, simply because every movement, every concentric contraction, that tend to be corresponding eccentric contraction to allow you to complete the repetition. Every exercise you do, from squat to chin up to push-ups to bench press, will require you to do both eccentric phase and concentric phase. Only thing about those exercises is that intensity during eccentric contraction tend to be a little bit lower because, as you know, your muscle can generate greater tension eccentrically. So even though you're lowering the same load as you lift, the effort required shouldn't be as high. When we talk about eccentric component, we're really talking about exercise that emphasize the eccentric phase. So anything that requires you to absorb force or decelerate quickly, so landing from a box jump, for example, has a high level of eccentric load associated with it, and those things perhaps should be kept to minimum initially. Another strategy that has been suggested is to start training at fairly low intensity and then gradually increase as one progresses. This sort of, I guess, goes in the same vein as the initial recommendation of lowered eccentric component. If you start gently, there's a good chance that you will not get as sore as you commence exercise. Only thing to note is that it is really difficult to get rid of muscle soreness entirely, particularly if you've been out of condition for a long period of time, or you start a new activities for the very first time. So start light may only assist in decrease the level of DOMS experience, but it might not get rid of it entirely. And this leads to the final strategy that has been recommended, and you will read this in some textbooks, so I didn't make this up, is that it has been recommended, well, if you're going to get sore anyway, one, and just go hard early, you'll get really sore initially, but your body will adapt and respond, because what will happen is, as your body becomes accustomed to the exercise, the delayed onset muscle soreness response will not be as severe, or may actually cease altogether in the future. So early pain, early initial soreness will mean that less pain in the future, or after future training session, that is. That concludes our presentation on delayed onset muscle soreness. Thanks for listening.